You hear a physiotherapist talking to a patient called Miss Wayne. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Ms. Wayne, as this is your first appointment with me, I'd like to ask you a few questions and get to know a little bit about your medical history. It's also a chance for you to ask me any questions you might have.
Sure.
I understand from your GP that you have arthritis.
That's right, yes. It's in my hands and wrists mainly. The finger joints in my hands get really puffed up when they're swollen, like they are now. The pain can get so bad that it stops me doing a lot of very simple things. Things like having a shower or getting dressed. Then there's the trouble I have making breakfast. Anything where I have to grip and move my wrist, like holding the kettle and pouring, or buttering some toast. Well, you get the idea. It's not like I'm an old woman. I'm only 40.
I see. Tell me about your work.
I used to be a hairdresser, but I had to give it up after my hands started getting really bad. I couldn't just sit around the house and do nothing, though. So now I go to the local primary school where my kids are and help the children with their reading. And just lately, I've started helping out on a telephone helpline for people with disabilities. They have these special hands-free phones, so it means I can do the work without needing to use my hands so much. It's only a volunteer position, but I really feel like I'm doing something worthwhile.
Is your mobility affected at all by the arthritis?
I do have trouble getting in and out of bed or out of a bath. I also need help getting out of a chair if it's a bit low. I move around the house with the walking aid I have, and when I go out, I tend to use a wheelchair. Our car has also been modified, so at least I'm independent. I can go to the shops or out with friends.
I'm guessing you've had physiotherapy treatment before.
Yes. In the past, it's mainly consisted of heat treatment, but now I'm really interested in some sort of gentle exercises, if that's at all possible. I also really want to make sure that my hand splints are still helping and not making the condition worse.
Sure, I can look at that for you.
I've also been to an occupational therapist before. I needed help when things started getting really difficult around the house. I found her very helpful. She had lots of gadgets to help me do things like dressing and cooking, and so many good ideas about how to help with my tiredness without making the pain worse.
Okay, we can talk more about some of the techniques you use to help you at our next appointment. What about your medication?
I take analgesics for the pain mainly these days. I used to take those, those anti-inflammatory drugs, but the benefits seemed to wear off and they started making me feel sick, so I had to stop taking them. I do sometimes get a steroid injection, but not very often. It works really well at reducing the pain for a few weeks, but it hurts like hell. Dr. Wong has mentioned a steroid tablet I could take, which will work in a similar way, so we might be looking into that soon. And a couple of times a day I have an analgesic cream that I rub into my hands. I don't know if it really works very well though.
Hi Hannah, nice to meet you.
Hi.
So I understand that you were referred to me by your GP because you've been experiencing some anxiety difficulties.
Yeah. I guess it kind of started like 5-6 years ago.
Okay.
It escalated a bit. I've just recently moved out from living with my parents, so it's made it a bit worse, I think.
Okay, is this the first time that you've left home?
Yeah, it's the first time actually. Yeah. I was going to a few years ago. I just thought it'd be easier to stay home. So.
Okay, so it's been quite a big step and a big change, and it sounds like that was what led you to go to your GP.
Yeah.
So how has that changed things for you?
Do you know, it's kind of, I haven't really told anyone, so I mean, it's made it like better in the sense that I feel hopefully this is it, like it'll help. But I don't know, I don't like thinking that I've had to do this. I never thought I'd like be the kind of person who'd have to actually go and like get help, if that makes sense.
Okay, so how do you feel about being here today?
A bit like scared. I don't know, hopefully it will help.
Okay, so you've been feeling a little bit anxious about today?
Yeah.
Okay, so I guess just going back to why you went to the GP and how you've ended up kind of coming here today. So it sounds like you've been experiencing anxiety for quite a few years, but just recently you moved out of home for the first time, and that was what kind of led you to go to the GP. So how did that change things? How were things after you moved out?
I thought that they'd be better, but because I thought I'd have to kind of be independent, and it's actually a lot worse. I'm just kind of staying in the house a lot. I don't really have any friends or anything. I mean, my family come and visit a bit, but it's not, I don't know, it's kind of scary because I've just been kind of literally just in the flat by myself, which I always thought I'd like, but I don't actually like it.
Okay. So what are the kind of difficulties that you have been experiencing?
I mean, I'm a photographer, so I kind of, it's been stopping me a bit, my anxiety, from being able to get work, and because every time, you know, there's an opportunity that is kind of involving me having to interact with people, I just tend to just turn it down. So I was kind of making things hard in that respect, and just kind of friends-wise and everything, I just feel like I'm just kind of increasingly more alone. So it's kind of stopping me from making friends and, you know, like relationships and stuff.
Okay, so you said that your difficulties are getting in the way of you doing certain things, so they're stopping you from taking up kind of certain types of work, and as a freelance photographer I guess that can be kind of a problem. And they're also stopping you, or you feel like it's stunting you socially. You're not kind of able to make new friends and get to meet new people.
It was kind of easier when I was at home because I was obviously, I mean, my parents and stuff, that's fine, but you know, I'd go to places with them, or I'd kind of have people there, but more and more I'm just finding myself just staying in a lot. I mean, I went like 2 weeks ago for coffee with my friends, and the whole time I was just kind of wanting to go home again. So I don't want that to happen. I don't want to lose everyone.
So you're kind of worried about where this is going to lead to?
Yeah.
Okay. So you said that you first noticed the anxiety kicking in when about 5-6 years ago.
Yeah.
So you would have been about 19?
Yeah.
And what was happening around that time?
I guess I'd finished school about a year before that. And I mean, I've always been a bit shy at school, but it was never ever like it didn't really affect things as much as, not at all as much as it has been doing the last few years. I guess it just started when like my friends went to university, and I don't know, I felt like I was expected to kind of move out or just do something, and then it just kind of escalated from there. I'd just stop going to parties, or I'd just say no to invitations, or I don't know, I thought my job would help because, I mean, I love it. I really like doing photography, but I'm just kind of getting less and less work as it goes on. So, which is my fault, I keep saying no, but...
What kind of work is the most difficult for you in your job?
I guess when I have to kind of be working with other people, I don't like that. It's like when I'm trying to kind of would do an event or something where there's a lot of people there, not just photographers, but actual, you know, if I'm like taking photos of people, that, I don't know, I just kind of find myself saying no. I mean, I want to do them, but just it's scary, so I just don't do it.
So, I guess tell me a bit more about what happens then. So let's focus on maybe an invitation to do a job with, you know, it's going to involve photography with a group of people, and you're going to have social interaction. What kind of thoughts go through your head?
I mean, I get really hot and sweaty, and I feel like everyone's kind of looking at me and thinking that I'm just like really stupid, and I feel like they're all going to be staring and thinking I just can't do my job and I'm just an idiot, and I mean, they'll think that I just look like a weirdo, and I just kind of just try and get out of the situation or just focus on something else. So that's why I like doing shots where it's just me and the camera, because then I can just put all my attention on that instead of having to, you know, be with other people.
Okay, so it sounds like you have quite a lot of thoughts rushing through your head then at the point where you get that invitation. You think, people will look, people will stare, people will think I'm a weirdo.
Yeah.
So there's quite a lot about what you think other people will think.
Yeah.
And how does that make you feel?
Just makes me feel like an idiot. It makes me feel like I just shouldn't even bother trying to do it anymore. I should just go home, and I think I just don't want to be in that situation. I just feel like everyone else is fine and they're normal, and I'm just the freak who can't like do normal things. And
Okay.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best, according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear 2 nurses conducting a patient handover. Now read the question.
Mrs. Garner's a 73-year-old who came in because of an exacerbation of COPD. This is day 3. Today she's down for a repeat chest x-ray, and that's all booked in, and her leg dressings need to be done. She has bilateral ulcers. Oh, and you'd better chase up the report on her sputum sample. We should have had that back by now.
Okay.
There's a history of ischemic heart disease and type 2 diabetes, peripheral vascular disease and peripheral neuropathy. She's been treated with IV antibiotics, steroids and nebulizers. She's mobile with a walking frame but gets breathless. She's down as high risk for falls.
Sure. I'll continue to monitor her fluid intake and check that she sticks to the diabetic diet.
Great.
Question 26. You hear a GP talking to a patient. Now read the question.
So, shall we have a look at your blood test result? So, what we're testing for is the level of hemoglobin in your blood. And just to show you, the normal range for women is between 11.5 and 16 grams per decilitre.
Oh, yes.
And this is your level of hemoglobin. It's 8.7.
Oh, I see.
And what this tells us is that you're suffering from iron deficiency anemia.
Oh, yes. I thought that might be the case. That would account for the lack of energy and the, lethargy. I think that's what you called it last time. So, perhaps I need to look at my diet, increase my iron intake?
Well, what I'd like you to consider is taking a course of iron tablets. This can be a really effective treatment for the condition, and what it does is it supplements the amount of iron you're getting in your diet.
So, does that mean I can go on eating normally?
Not necessarily. I think we'd better run through what that phrase means in your case before I answer that question.
Okay. Question 27. You hear a senior nurse briefing a colleague about working in the recovery room. Now read the question. Okay, so this is the recovery room where you'll be working. Patients come here directly from theatre. It's their first stage recovery before going back to the ward. Here we have a monitor, and on that you can see all the patient's vital signs from theatre, okay?
Right.
So you check that it's on and functioning, attach the BP cuff and pulse oximeter, and you're ready to make your assessment. The system then prompts you in terms of what to do next with the patient.
So, do they get extubated in theatre?
It depends. Mostly they do, and that's ideal. But sometimes it happens outside. If they come out with an ET tube in place, then it's probably because the doctors want to keep it there during recovery. But if it's a laryngeal mask, then the anaesthetist will see to that. We just have to ensure that the patient's kept stable. Question 28. You hear a dentist talking to a patient. Now read the question. Okay, so today I'm going to prepare the tooth for the fitting of the crown, then take an impression.
Oh, really? I thought I was having the tooth filled. Have I got the wrong end of the stick then?
Okay, well, if you remember, last time you were here, we discussed the various options for the tooth because there's already a big filling in it that's fractured.
Yeah, and I thought you said you'd be replacing the metal filling with a tooth-coloured filling made out of some sort of composite material.
Oh, yes, I see. Actually, what we discussed was either a new metal filling, which may or may not stand the test of time because there's going to be a lot of stress on what's left of that tooth, or go for a tooth-coloured crown instead, which would be more robust.
And is that what you quoted for in terms of the price?
Oh, yes.
Oh, okay. Let's go for it then.
Question 29. You hear a triage nurse in the emergency department talking to a doctor. Now read the question.
Excuse me, doctor. I'm getting concerned about one of the patients I've triaged this evening. He came in with pain in his right shoulder going down the arm, and I put him down for an ECG and blood work. But he's now saying he feels feverish, and he's asking me how long it's going to be before you can see him.
I see. How long's he been waiting?
Around half an hour. The thing is, he's got an infected wound on his leg. Says he's had it for a while, and it doesn't seem to want to heal. He didn't tell me about this initially. I've looked at the wound, and there's clearly inflammation and some discharge. But what's worrying me is that his speech is getting rather slurred, so I'm concerned that it might be sepsis. I think we should move him up the list.
Okay. Thanks for flagging this up. I'll take a look at him straight away. Question 30. You hear an eye surgeon briefing some new staff at the eye clinic. Now read the question. One of the biggest challenges for us can be deciding what's normal and what isn't. Looking at the back of people's eyes, as we do all day, what strikes you is the enormous variety of shapes and sizes you see there. The optic nerve may be oval, it may be round, or it can be irregular in shape, and all of that can be perfectly normal. So we get lots of referrals, particularly of children, where an optometrist's observed something a bit funny at the back of the eye, and they want us to check it out. Well, that's fine. If they err on the side of caution, that's better than missing things. And from our point of view, it's all worthwhile. After all, it's only by looking at a great many healthy eyes that you learn to diagnose the problems that we need to deal with.
That is the end of Part B. Now, look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a doctor and a nurse on the symptoms, signs, and causes of vulvovaginal candidiasis infection. You have 90 seconds to read the questions 31 to 36.
Hello, doctor. Can you explain how vulvovaginal candidiasis infection occurs, its symptoms, and its treatment?
Vulvovaginal candidiasis is a syndrome rather than an infection, and diagnosis of vulvovaginal candidiasis does not rely on clinical or laboratory criteria alone, but a combination of these two. Usually, vulvovaginal candidiasis is caused by C. albicans, but can occasionally be caused by other Candida sp or yeasts. Typical symptoms of vulvovaginal candidiasis include vaginal soreness, pruritus, dyspareunia, abnormal vaginal discharge, and external dysuria. However, none of these symptoms are specific for vulvovaginal candidiasis. About 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have two or more episodes. Based on clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis, likely to be Candida albicans on immunocompromised women. Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis. Several vulvovaginal candidiasis, non-albicans candidiasis, women with diabetes, immunocompromising conditions, debilitation, or immunosuppressive therapy. By the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness, a diagnosis of Candida vaginitis is suggested clinically. Signs include fissures, vulvar edema, excoriations, and thick, curdy vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a Gram stain or preparation of vaginal discharge demonstrates budding yeasts. Pseudohyphae, hyphae, or a culture or other test yields a positive result for a yeast species. Use of 10% KOH preparation in wet preparations improves the visualization of mycelium and yeast by disrupting cellular material that might obstruct the visuality of yeast or pseudohyphae. Examination of a wet mount with KOH preparation should be performed for all patients with symptoms or signs of vulvovaginal candidiasis. For patients with negative wet mounts but existing symptoms or signs, vaginal cultures for Candida should be considered. In case Candida cultures cannot be performed, then an empiric treatment can be considered. Identifying Candida by culture in the absence of signs or symptoms is not an indication for treatment, since approximately 20% of women harbor Candida sp and other yeasts in the vagina. However, postcoital testing for yeast is not approved by Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vulvovaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated vulvovaginal candidiasis have no identifiable precipitating factors. Short-course topical formulations effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are highly effective than niacin. Treatment with azoles results in relief of symptoms and negative cultures in 90% of patients who complete therapy. Over-the-counter intravaginal agents, clotrimazole, 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole, 2% cream, 5 grams intravaginally daily for 3 days, or miconazole, 2% cream, 5 grams intravaginally daily for 7 days, miconazole, 4% cream, 5 grams intravaginally daily for 3 days, or miconazole, 100 milligram vaginal suppository, 1 suppository daily for 7 days, or miconazole, 200-gram vaginal suppository, 1 suppository for 3 days, or miconazole, 1,200 milligram vaginal suppository, 1 suppository for 1 day. Teoconazole, 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agents, butoconazole, 2% cream, 5 grams intravaginally in a single application, or turconazole, 0.4% cream, 5 grams intravaginally daily for 7 days, or turconazole, 0.8% cream, 5 grams intravaginally daily for 3 days. Turconazole, 80 milligrams vaginal suppository, 1 suppository daily for 3 days. Oral agent fluconazole 150 milligrams orally in a single dose.
Here in the health report, we cover all sorts of research. The Mediterranean diet, what fat is right for you, how much salt is safe, diets to protect you from diabetes, early death, heart disease. So this next segment is actually a bit perturbing. We're being told that almost all this research is wrong. Yes, John Ioannidis is Professor of Medicine at Stanford University, and he says the scientific approach taken by nutritional researchers is nowhere near rigorous enough, and we have to go back to basics if we're to learn anything significant about how diets impact health.
Thank you for inviting me.
Now, we've had you on lots of times before, talking about various things and demolishing a few iconic areas of health and research. You're arguing that nutritional research needs radical reform. On what basis do you say that?
Well, there's clearly a factory of papers being produced in nutrition epidemiology in particular that don't meet very high standards of credibility. The type of research that is being done in nutritional epidemiology, it's not an issue that there's bad scientists involved in it. You know, maybe excellent scientists are involved in it, but the odds of getting it right are extremely small.
Let's look at that in a moment, but you quote in your paper some really bizarre conclusions that you might come to from if you've believed past nutritional research. Do you want to just tell us some of those bizarre findings in their relation to either longevity or shortened lifespan?
Most of these studies are not experimental. They're not randomized. They're just observing people who report what they eat, and they take that seriously, that this is reflecting exactly what they ate, which is one major assumption. Second, people take these behaviors and these numbers as causal, which means that they look at the numbers and they translate them to an effect of these nutrients or of these foods on mortality. And then they also make another assumption that these risks are applicable to the entire lifespan. So then, let's take a number like 15% relative risk reduction in mortality or 15% increase in survival, which is a typical number that comes out of these studies. And this is the number that is the summary of all the data, for example, on what is the benefit with eating 12 hazelnuts a day. If you translate that to a gain in survival, you take 80 years, you multiply that by 15%. This looks like a 12-year gain in survival just by eating 12 hazelnuts a day, or literally one hazelnut a day would give you one more year of life as a benefit. It's a ridiculous calculation. It is not so, of course. Even if you believe that one of these foods or one of these nutrients or a couple of them may be important, it's impossible to believe that every single food, every single nutrient will have such tremendous benefits or such tremendous risks.
So you get there because of there's multiple levels of unreliability. Is that what it is? That essentially the food diary is unreliable, they're not controlling for other factors such as education and other environmental factors properly, and they all conflate together to give you bizarre results? Is that what's going on?
Exactly. It's a problem at multiple levels. It's an extremely difficult field to study. And it doesn't mean that observational studies, that epidemiological studies get it wrong all the time. In many other fields, the problems are much more straightforward. For example, we know for sure that smoking is killing zillions of people. It will kill 1 billion people in the next century unless we do something. But the effect of smoking is huge. The risk increases 20-fold if someone is smoking for getting lung cancer.
But just to challenge you on that, whilst we're confident in smoking, why are we confident in smoking and not in coffee? Because there have been no randomized controlled trials of getting people to smoke and other people not to smoke. I mean, so that's still on observational studies, is it not?
The major difference with smoking is that the effect is tremendous. We're talking, as I said, of a 20-fold increase in risk of lung cancer, 10-fold increase in cardiovascular disease. Many other diseases have tremendous increase in risk. For each single nutrient, each single things that we eat or drink, the effects, even if you take these studies literally, are much, much, much smaller. And based on what we know from some randomized trials that we have done, the effects are pretty much close to null, if not exactly null. I mean, it's very likely that they're exactly null, which means that it's a complete waste to even try to pursue them any further.
What about...
We cannot really use epidemiology to study a relative risk of 1.01. We can do it to study a relative risk of 20, which is what's the case for smoking.
And just to dissect that out for people don't know the statistics, is that 1.01 is, there's no effect, 1.01 is just tiny, whereas 20, an effect of 20 is 20 times the risk. So 1.01 is just a little bit over what would be normal and probably within normal limits. So what about eating patterns? I mean, you yourself have been involved in trials of the Mediterranean diet.
So I think that eating patterns in theory might be able to get you a little bit of that complexity of all these nutrients interacting together. But even those are very difficult, if not impossible, to study within an observational context. Again, you have most of these problems operating. Number one, you need to ask people what type of eating pattern they're following, and responses may be accurate or very often may be very inaccurate, especially if you try to recall what you ate and tell what you're doing. Just try it to yourself and see whether that information would be reliable. The second problem is that you still have extreme complexity among all these nutrients. We have over 200,000 different foods that you can combine in different ways. There's no clear eating pattern that each one of us is following. We follow different eating patterns in different periods of our lives and different days even. And it also changes all the time. If you superimpose the way that we react to all of these chemicals that we digest, our metabolic profile, also our genetic profile might affect how we react. Circumstances, our environment, socioeconomic factors that dictate what we decide to eat or not eat, and what we do or don't do with our life at the same time. It's an extremely complex system.